Well, great. Well, let's go ahead and get going. I'm just by brief introduction before I pass it off to Dr. Rudy Rodriguez for the formal introduction. So, I introduce myself. I'm Sean Greenlee, the Program Manager at the Department of Medicine, DEI Office, and welcome to our quarterly diversity lecture series. And we have the honor to have Dr. Eliseo Pérez-Stable here to speak to us today. And with that, thank you guys all in the audience for joining, and I will pass that over to Dr. Rodriguez.
Great. Um, it's a pleasure to introduce Dr. Pérez-Stable, who's a professor emeritus at UCSF and the former director at the National Institute on Minority Health and Health Disparities. The Institute, if people aren't familiar with it, seeks to advance the science of minority health and health disparities research through research, training, research capacity development, public education, information dissemination. Dr. Pérez-Stable practiced general internal medicine for 37 years at UCSF before moving to the NIH in September of 2015. He was professor of medicine at UCSF and chief of the Division of General Internal Medicine for about 17 years. His research interests include improving health of racial and ethnic minorities and underserved populations, advancing patient-centered care, improving cross-cultural communication skills among clinicians, promoting diversity in the biomedical research workforce. For more than 3 decades, he led research on Latino smoking cessation, tobacco control policy in the US and Latin America, addressing clinical and prevention issues in cancer screening and mentoring well over 70 minority investigators. He's published more than 250 peer-reviewed articles and was elected to the National Academy of Medicine in 2001. As the article in Nature in April 2025 called it, they called it one of the darkest days when NIH purged leadership amid mass layoffs, which included NIH directors, including Jean, I think many of you remember Jean Marazzo, who was the sixth director of the National Institute of Allergy and Infectious Disease, and Dr. Pérez-Stable. So despite these dark times, we need to remind ourselves of the importance of the work ahead as we try to combat health disparities. On a personal note, I've known Dr. Pérez-Stable for a little under 40 years. I was a med student when I met him, and he was a junior attending at UCSF. And when I eventually joined faculty at UCSF, we got to work together on a lot of projects. He's always been a trusted career mentor. So thanks again to you, and thanks again for joining us today. And I'll turn it over to you.
Thank you so much, Rudy, and for all of you continuing to do all this work. So I'm out of practice of this since the pandemic, but I'm hopefully can get, let's see, to my shared screen. If not, I may have, it doesn't look like I'm able to get it. Okay, there we go. Okay, Sean, you may have to bring on the slides from your end because I can't seem to, I've forgotten about this step. When I hit the share button, I'm not getting my slides showing up.
Great,
Okay, there we go. You got it. All right.
And just one quick note, logistics notes. There will be an opportunity for people to ask questions at the end. Dr. Rodriguez and Dr. Asenchin will facilitate those questions, so please drop those into chat along the way.
So thank you, and I'll ask her next. So when I'm ready. So as Rudy mentioned, I spent almost 10 years as director of the National Institute on Minority Health and Health Disparities. Happy to talk about that in the discussions if people are interested. But being part of UCSF for so many years, I am a professor emeritus and now use that as my sort of professional identity. Next slide. So health disparities research is really built on the fundamental basis of a law that was approved in Congress in the year 2000 that started NIMHD, and it defined race and or ethnicity as self-identified construct and socioeconomic status. We can talk about how that can be measured as the fundamental pillars of health disparity science, with the additional influence of place of residence, primarily thinking about rural versus urban. We'll come back to that too. These are all factors in statute. When the National Center on Minority Health and Health Disparities was founded in 2000, and these were re-emphasized and restated in the Affordable Care Act when the center was elevated to be an institute in 2010. So something changed. Okay. Health disparities really then has this concrete definition that if you have one of these factors, race, ethnicity, SES, or rurality, or more likely geographic location, and have a worse health outcome compared to others, then that's what we define as a health disparity. And I emphasize these basic things because a lot of times people use disparities interchangeably with differences, or use disparities to refer to worse outcomes in groups that do not fall under the underprivileged or the ones with the social factors that are adverse. Next slide. So building on that, health disparities science, where are we, after all these years? It's been 25 years since the center was founded, over 25 years. One thing is intersectionality. So race and or ethnicity and socioeconomic status with all other demographic factors, age, sex, whatever you can think of in terms of demographic or social factors. Intersectionality with clinical conditions as well, all need to be considered. So with diabetes, heart failure, cancer, the leading causes of death in the US. Stratifying by race and or ethnicity when the sample size allows is really important to be able to address mechanisms and to understand why we see these outcomes. So not always sort of adjusting statistically and then moving on, because that really doesn't advance the field in knowledge. We also had reached the conclusion probably 2-3 years ago that we should stop comparisons to white populations, which was always the norm, saying, well, blacks have, 3 times more this, or Latinos have 2 times more this compared to whites. And we really move away from that and just say, what are the aspirational goals for the populations? Where should we be as a nation, as a country, as a population in terms of health outcomes? Maybe 90th percentile of that would be good, or 80th percentile even, because we sometimes don't reach this. And use that rather than comparison to another group. And I think that's something that I would encourage people to really focus on. And then really expand on the role of place. And I'll get into this more in a collaborative work with Institute for Health Metric Evaluation at UW. We're seeing the differences across the United States is just really eye-opening to understand it. And in this, both in terms of geography on a macro level in a way, and also the built environment on the more sort of local level. Next slide. So language matters, and I'll say this, I'm going to say this every time I speak from now on. So back in 2020, with the events of George Floyd, the murder of George Floyd, there was a big movement across the entire country. We're all familiar with that. And in the health research world, in the health academic health institutions, a lot of people started saying, well, we should use health equity. It's a better term. It's a nicer term. It's a good term, as opposed to health disparities. And, we never publicly opposed it, but neither the leadership at NIMHD was not really in favor of this. And we continue to use health disparities. I think a major disadvantage of using equity as a term is that it doesn't have a definition. When you ask people, what is health equity? Nobody can really tell you, well, it's good health. It's everyone achieving their goal, their potential. And it sounds a little bit, aspirational. It doesn't really get to concrete, what can we do to make things better? It also is not supported by statute, as NIMHD's foundation is in what helped the term health disparity. So I'm not in favor. I mean, equity is a great word, and this should not confound the science of health disparities with the laudable goals of increasing diversity in the workforce and the inclusion of diverse participants in clinical studies, both critical things to do, and particularly around the workforce. I'll come back to that, where we have a lot of ways to go. The confusion of terms not only was in the health disparities research community, but also in NIH itself. Outside of NIMHD, people thought, oh, that promoting diversity in the workforce is health disparities research, or including more minorities in studies was part of that. A couple of institutes were not disoriented on this, but it was widespread in NIH, both at the time it was happening, I saw it, but also especially after the November 2024 election. And I think as a consequence, this has been targeted by the administration because they just attacked anything that was DEI, and they made disparities research part of equity because people were using the term. At least that's my assessment at this point. Next slide. Now, in the 2000 legislation, racial and/or ethnic minority populations, as defined by the census, poor people of any color, less privileged socioeconomic status, and underserved rural residents were included explicitly in that statute, and also empowered the NIMHD director in collaboration with the HRQ director to declare new populations as we saw fit. So both sexual minorities used to be sexual and gender minorities, so I did modify that because the NIMHD modified it. Were declared in 2016 by me, and in 2023, people with disabilities were declared. And that was more of a political process as opposed to a scientific one. I think the sexual minorities process was one that preceded my arrival at NIH, and I helped complete it at the time. Now, again, the social disadvantage that results in part from being subject to discrimination or racism is really a unifying factor for these populations, and then being underserved in healthcare. Next slide. Now, look at the census review of the OMB Statistical Policy Directive number 15, the link there. They haven't touched this yet, so we'll see. But in that directive, which was officially published in March of 2024, but it had been going on for about 2 years, the process of it through a committee at HHS. This is the new recommendation. This is how the 2030 census is going to be. And I would encourage every researcher and everyone who wants to know what your race ethnic population looks like to use this. You don't have to wait till 2030. The federal government, I think, had 5 years to change all their forms. So it's one question now. There's no more non-Hispanic this, non-Hispanic that, which I never really liked. And so it's mutually exclusive categories, 7 categories of race and or ethnicity. And they say race and or ethnicity, that's what we're using. And these are the official names, American Indian or Alaska Native, although a lot of people use Native American as well, Asian, etc. You can see these for yourself. And it does also have a second part, next slide, which people forget. And it's asking every group to then identify mostly their geographic background, although there are some exceptions to this. Obviously for American Indians is tribal affiliation. Now, in previous census, American Indians, Asians, and Hispanic or Latino were asked about their background, and so Native Hawaiian or Pacific Islander as well. So the new addition is that whites are being asked, and the listings here are based on the most common heritage in the census in 2020, although there's always room for other. And gives you a sense of where the population, the immigrants, the heritage of those populations are. And then I didn't mention, but Middle Eastern or North African were added as a separate group, so that it's now 7 categories. And Middle Eastern or North African technically would be another ethnicity. So there's no longer this idea that the only ethnicity that is acknowledged is Hispanic or Latino as opposed to what we have called race. And so why the construct is really looked at as a single construct, even though you can go on, because it's a social construct. You can go on and on about, what could be or couldn't be. But this is what the federal government agreed on in 2024, at least for now. Next slide. Now, assessing socioeconomic status can be very complicated, and it ultimately boils down to wealth. And so not always do you get to that by asking about education or income. It's a lot easier to get education attainment, certainly in clinical context and in research context. And it's now the data are very clear that if you have a college degree, you're clearly healthier long term, not only mortality wise, but lower incidence of chronic diseases. You just have better outcomes, better behavior, smoke less, on and on. Now you can ask about income. The problem with income is that many times people get very sensitive about that, and there's studies, old studies that show that there's underreporting at both ends of the scale. So poor people underreport, and wealthy people, I should say, underreport. So the whole idea of using income is great, and you can sometimes use both. And I think one study we did years ago in with NHIS, with National Health Interview Survey, we were able to use both and find some interesting findings in terms of smoking and the population. People sometimes also report it as ratio to poverty, and that becomes easier to manage statistically. Traditionally, in the Whitehall study in the UK, the occupation and work was one of the classic ones. So you go from labor to business to professionals. So it has to do with how much you controlled what you were doing. Now, of course, a lot of it is been emphasized on prestige, but it's a harder variable to operationalize to do analysis with, I think, but it's still important and something that people do continue to measure. Life course SES, how did you grow up, is really hard to get at. Not very much has been done in this, not a lot of studies on it. And you can do it. It's always usually recalled, how did you grow up? And then you have to sort of adjust to that. And in pediatrics, in children, parental education is often the most reliable. And you can always impute data from the census tracts, which remember is just the population average. If you have people's exact address, then you can do it through census tract or census, and that will help you get at the variable. Next slide. Not always easy to do. Just some examples. This is two from cancer. So this is cancer incidence by site and race ethnicity, and looking at the 5 most common cancers in females in the U.S. over a course of about 5 years. And you can see there's variability. Without getting into the why, we can understand that, let's say, lung cancer is attributable risk of cigarette smoking is so high. We know that African Americans, American Indians are more likely to smoke, and so are whites, and we see much lower rates of lung cancer in Latinas and Asian women. And so also with cervical cancer, there's differences in HPV infection, which accounts for a large of the variance of incident cervical cancer. But we see these differences by race and ethnicity, and so this is the value of it. Next slide. And then on the socioeconomic side, this is a paper from a few years ago. You see the mortality in these quintiles related to index of concentration at the extremes and mean adjusted all cancer mortality rates. And the least privileged quintile had the highest overall cancer mortality compared to the most privileged side. So many will say, well, it's a no-brainer. We know this, and we understand this. But I think in the field and thinking about health disparity science, these two variables are essential, and they are critical to understanding, with the third one being, again, geography. Next slide. Now, in collaboration with Tom Leviste, who is at Tulane, and Daryl Gaskin, who is at Hopkins, we funded a contract for Tom and Daryl to redo an analysis they had done in the around 2012 or so on the economic burden of racial, ethnic, and in this case, educational health disparities. They had only done race and ethnicity. It was actually published in some obscure journal. I had never heard of it until I got to NIH. And eventually I got around to saying, well, we should do this again. And so this one was published in JAMA not quite 3 years ago. And so we hoped, we still hope that the economic argument can influence some policymakers. Or you say, well, by race and ethnic groups, disparities account for $450 billion in a single year, 2018. And so we'd expect this to be an annual. Now, the methodology was different, but the amount has gone up. And if you use educational levels, again, emphasizing the importance of education, even some college is worse off than a college degree, but clearly people with high school or GED equivalent, I mean, that's the majority of the population where we see the excess economic burden from disparities. And some of the causes vary. In Black African Americans, premature mortality was the driver. For Hispanic Latinos, it had to do with management of chronic disease and late services. Next slide. Now, in 2019, I think, after some conversations, I learned about the Global Burden of Disease Project. We funded a contract with the Institute of Health Metric Evaluation at University of Washington, really to look at burden of disparities by race and ethnicity in the United States. I was familiar with the work they had done globally. There had been some work done in the US. But we really wanted to see this done at the national level. Of course, then something happened like COVID, and the methods were complicated, and so things were delayed. But go ahead, next slide. And this is our first major publication. It was in Lancet 3.5 years ago. And it confirmed what we kind of already knew. And in fact, the CDC published the life expectancy data for Asians around the same time. It had not been published. Asian Americans have the longest life expectancy, and we weren't able to separate Pacific Islanders who probably don't have the same health outcomes. But they're a very small population, and methodologically was difficult. We can discuss. Latino Hispanics, second, you see whites in the middle, blacks improving substantially to some extent, and then stabilizing. And then the American Indians, again, greater confidence limits are much wider, but still have the worst health of any of these groups in the country. A couple more slides on the U.S. Burden of Health Disparities Project. Next slide. This is published now or in press, in Archives of Public Health, is maternal mortality. And when you see a map, you see data like this, we know that, what's maternal mortality? It's about 1,000 deaths a year. So at most, probably. So it's a pretty uncommon cause of death, yet it got a ton of attention. And of course, it's horrible. A young woman to die because of within a year of childbirth. This is how it's defined. But you can clearly see that for, let's say, for African American women, for Black women, you see in the South what's predominantly where the problem is. When we first discussed these data, Chris Murray said, "What's going on in Southeast Georgia?" Because it lights up. And you can see that for other populations, American Indians, Alaska Natives, the upper Midwest, the Montana, Dakotas area is much worse than, let's say, the Four Corners, Arizona and New Mexico. And so I think these kind of analyses, these kind of data will really help provide insight for local interventions. And this is where we're driving. Next slide. Another example, it is published in the Annals of the ATS, the American Thoracic Society, on lung cancer mortality. And then similar patterns. Not every outcome, by the way, is the Southeast area, the absolute worst. We do see some differences. American Indians, you can see again the difference, lung cancer, because actually it's been known for many years that the Southwest tribes don't smoke as much. Yet the upper Midwest tribes from the Strong Heart Study and others data do smoke. And not tobacco use in ceremonial ways, which is different. This is cigarette smoking, combustion, inhalation of combustion. And then you can also see for the other groups. And again, refer you to the publication. Next slide. Disparities in diabetes mortalities, looking at rural versus non-rural counties, and then using standardized mortality rates unchanged over the course of about not quite 20 years in rural counties, but significantly lower in medium and small counties and metro counties. In looking at the decrease over the course of this time, where you would expect, based on, even the analysis we did with the global burden of disease, diabetes mortality has generally decreased significantly over the previous 20 years, so 2000 to 2020. Often, I think predominantly because of the medical model, because we just know how to treat it better and we have better drugs. Even though we're all, as clinicians, people are frustrated when their patients aren't taking their drugs or their A1C is 12. But that is less and less frequent than it was, let's say, 30, 40 years ago. And so the rurality, the counties that are rural have the highest diabetes mortality. This is a major issue. Next slide. And haven't been improving. Another sort of creative approach. This is from can't quite see this slide myself, but it's okay. The map of Puerto Rico, and it was trying to match asthma exacerbation with elevation, so geographic, and then in the case of Puerto Rico with African ancestry. The colleague who worked on this, Esteban Bouchard, was interested in the genetic markers, the ancestral markers, and because asthma is something that is related to your environment, and of course the exacerbation rate, meaning an emergency department visit. So this is another approach of trying to look at this, which I think was creative in thinking about disease outcomes that we care about. Next slide. Hopefully this, yeah. So at NIMHD, early on, we developed this research framework early on in my time there, I should say. And I had, in part, thought about this when I was on the National Institute on Aging Advisory Council. We were charged with developing a research framework for disparities research at aging. And I worked with Marie Bernard, who was then the deputy director, and I forget a couple other colleagues who were on the were staff and one other colleague on the council. So I came to NIMHD, I said, we need a framework. And the staff did this. I signed off on it, had input, of course, but this was not my creation. And it has been very helpful, I think, to many scientists in thinking about what the field should be about. And it's, the mechanisms, when you think about what we call domains of influence over the life course, there is biology that's important, behavior, of course, the physical environment, social cultural environment, and then, of course, the healthcare system. I think the layer of the healthcare system was my addition because being a former primary care clinician, I really wanted to make sure that that was included. Because you can make disparities worse or really address them in that context. And individual, interpersonal, community, and societal. And hopefully this will help move the field in the direction of greatest needs. We do have, looking at NIMHD's grant portfolio at one point, we still fund a majority of the grants in the individual column. So getting grants funded in that sort of community societal side is harder. It's harder science, I think, to do in terms of you have much less control. Next slide. Get rid of this notification. So one of the mechanisms that everyone agrees is driving a lot of disparities, and not exclusively, but one of the ones that are important is the burden of discrimination. And it isn't a sort of you're being racist, you assault someone or you kill someone, or, the hangings, etc. No, or the murder of George Floyd, etc. This is really about chronic exposure, it's chronic stress, and it builds up over time. There may not be a specific event, and this survey that was done by Kaiser Family Foundation, published a couple years ago in a report. They had done a previous one probably about 10 years earlier. And they asked specifically about healthcare. In healthcare visits over the past 3 years, have you ever felt a doctor, healthcare provider, et cetera, treated you unfairly or with disrespect? because of your race or ethnic background. And you can see the results. 3% of white respondents said, yes, this has happened to me. 18% of African American respondents. And the other groups were about 10 to 12%. So, and this is the first one, or racism. Um, and structural discrimination, often harder to get at. We actually had a funding opportunity announcement along or request for proposals that was set aside where we had 14 institutes ended up funding R1s, in addition, including us. $38 million were awarded in that year. Was right around 2020. We wrote the FOA. We held it until February of 2021. And then Francis Collins said every institute should do this. Most signed up, not all, and 14 ended up funding. So I don't think those grants have all survived the 2025 purge of research, but many were reinstated once they, tweaked the language. But this is trying to get at this, how does this influence health outcomes, and how can we intervene in these things? And a variety of things. The underlying basis of this often is residential segregation. It is a cornerstone of the system developed in the 30s as a planned policy. You limit family equity. Families build equity through purchasing property. And if you don't have that option, because you live in an area where equity doesn't go up, that was a structural factor. And that was actually done as policy under the administration of Franklin Roosevelt. So it wasn't necessarily something coming from a specific perspective. It was the government doing that. Of course, measuring and operationalizing this for health research, I think, is important. And there's been a number of scientists who have worked in this field. Next slide. NIMHD also has resources that I encourage people to tap into. And I checked these websites these links were still working. The Phoenix Toolkit is something at NIH-wide that we decided again a number of years ago to launch is that we need common measures. We can't have people saying, "Oh no, I don't like the way they asked that question about race, so I'm going to ask it the way I like it." Or I'm going to ask about education this way versus that. So we try to encourage the field to do that by creating these vetted measures. Of course, most of the challenges is not in standard demographics or race ethnicity questions. And I encourage people to take a look at what we have done. We had 2 waves of review with an expert national committee that was formed, took about a year and a half. This is a whole process that had been worked out at Phoenix. NIDA and cancer and aging and others have used this. We were getting close to the idea of saying we should have a requirement that people use the Phoenix Toolkit, but I hadn't quite taken that step before I was put on leave. And you see the structural protocols that are included here. And so I, again, encourage people. Next slide. And then with the advent of artificial intelligence and the effort to do that, one of our staff created this Science Collaborative for Health Disparities and Artificial Intelligence Bias Reduction, trying to get at the issue of bias in AI, and also to really help our community, the NIMHD community of researchers, to understand, even if they knew nothing about it. I mean, I would be a great student for this because it's one area I'm not going to really learn much more about than what I know now. But in the effort that we did, we've created this collaborative. It's actually supported also by nursing and Office of Data Science Strategies. Again, the link still works. I don't know the status now, but there are a number of things that you can get from this and encourage people to consider this. Next slide. Now, community engaged research is really critical. And again, this is something that we had a lot of impact in. Initiate in full partnership, listen to the population, shared governance, which is hard for academics, for scientists to do that. Partnerships that are based on trust, and you develop trust by working together. And it often takes time. People don't have that luxury sometimes. Mutual benefits, you bring complementary skills, and of course, because of what we do, we are focusing on health. And there is an important need to provide tangible financial support that is sustainable over time. Next slide. So two examples I'll give you. One is ENDED, which was the Rapid Acceleration for Diagnostics for Underserved Population initiative that I co-led with Richard Hodis, was NIH support for community engaged network to address testing for COVID-19. Congress appropriated money, we responded. And of course, testing quickly was not the only issue, but this is what we focused on. And we were able to develop and implement common data elements that about 80% of the projects adhered to, which was I was pretty amazed that they did. And of course, I wanted 95%, but I was ready to hear only 50%. Data sharing in a central repository. These data still exist of almost 500,000, about 500,000 participants. A number of other things that were done to disseminate science-based information. Next slide. Just to give you a picture of the country, of the extent of this initiative across the country. The grants were all for 2 or 3 years, so they were short. But we were from Seattle to San Juan, and out to Honolulu to Maine. Next slide. Now, from COVID, we also developed the Community Engagement Alliance, or we call SEAL. And SEAL is a platform for sustainable research infrastructure to support communities addressing differences in chronic disease outcomes. The mission to promote health, improve outcomes, and strengthen community engaged research. And to build trust in science, inclusion in research studies, and advance community-driven solutions. SEAL still exists, and it was a partnership, next slide, between the National Heart, Lung, Blood Institute and NIMHD. And we initially had support from one other institute and also from the Office of the Director before Congress allocated specific funds. And my colleague, and soon to be former director of NHLBI, Gary Gibbons, really expanded it by including the initiatives that NHLBI had on maternal health. We partner with environmental health on climate health. We also were creating a community engaged primary care research project. Actually, that got launched. We had enrichment initiatives with American Indian, Alaska Natives, and Native Hawaiian Pacific Islanders. Subsequently, NMHD received funding for American Indian Cancer, Native American Cancer Initiative, of which one of the grants was in Washington, although I'm not remembering the details now. And we're trying to link that to SEAL as well. Again, these links, the URL links work. Next slide. So let me finish the last few minutes on neighborhood. So what defines an unhealthy neighborhood? We go back to the history of what residential segregation is, built on redlining that has led to worse outcomes. This is, to some extent, happened in almost every city in the United States, less so in the West Coast, I would say, especially, let's say, San Francisco and Seattle, compared to every Eastern Seaboard city was affected by this. You see higher rates of diabetes, cardiovascular events, cancer with mechanistic studies. So in Washington, D.C., for example, I'd show you a map. Where do Black people live? Washington is 50%, not quite anymore, 50% Black. Well, you go to east of the river, east of the Anacostia River, and it's like 80, 90% Black. If you go to the northwest side, just south of Bethesda, it's the opposite. It's 90% white. So it's clearly residential segregation. I mean, we know this, and you can go to any city and find that. You also see higher incarceration, crime rates, lack of trees. That may be evolving slowly. Sidewalks aren't there. Access to full service supermarkets. I lived in San Francisco for for more than 37 years, and the Hunters Point Bayview, until I left, did not have a full service grocery store. They had lots of convenience stores with lots of alcohol, but no full service grocery. That's what residential segregation is about. That's what an unhealthy neighborhood happens. You also ask people about their perception, and the things that usually are asked about include, litter, noise, pollution, crime, and empty buildings or structures. Next slide. we did an analysis of the Hispanic community health study on this. One of the medical students working in my lab did this, created this idea and tried to find associations between perceived neighborhood problems and outcomes. And we did find some things where, moderate perceived problems predicted lower odds of screening for cancer in one of the analysis, and higher odds of current smoking. And perceived neighborhood problems predicted higher odds of smoking as well. Next slide. We did not find that perceived social cohesion, which is included in the SOUL and the Hispanic study questions. No, we weren't able to find any correlation, any association between that construct and benefits in terms of the same outcomes that I outlined earlier. However, there is interesting and important literature, often overlapping with mostly anthropologists or sociologists, about immigrant ethnic enclaves. So immigrants tend to come to the U.S., gravitate to a common neighborhood to provide sort of cultural protection, social support. They recreate some of their foods, and in the case of immigrants from Latin America in particular, or any country that's not English speaking, sort of language fluency. There are some studies. There is a not too long ago study out of California looking at this in cancer rates and ethnic enclaves. Seoul is not really susceptible to this because all of the sample was taken from ethnic enclaves, as we discovered when we tried to see whether we could do something with it. So we're still thinking about that. There is this moving to opportunity study that everyone should be familiar with, or at least aware of in research. It's an experimental study where people in 6 different cities in the United States were randomized to receive a voucher. They were living in subsidized housing to receive a voucher to move out of the area they were in. And the long-term follow-up of that showed that the women, most of them were single parent households, females with small children, that the women actually did better, less obesity, less glucose intolerance. The papers published in the New England Journal of Medicine. It wasn't a health study, mind you. It was a HUD study. But NIH added some money and added some measures. Pre-adolescents also did better. There were some challenges for particularly adolescent males in the move. And then there's an old study from the Alameda Population Laboratory that poor people who live in the East Bay Highlands, so in the San Francisco Bay Area, the Highlands are in the East Bay, are wealthier. And then the flatlands, where Oakland, Berkeley flatlands have less resources. And so, but poor people living amongst the rich people, or rich or better off people, had higher mortality over a 10-year follow-up. Again, what's the role of neighborhood? I mean, is there a benefit to having ethnic enclaves or having a sort of community of cohesion? Again, these are research questions that have not been fully addressed in my view. And then there are all data about the benefit of being in an integrated neighborhood. So taking aside the very wealthy who are going to do whatever they want, it is, I think, probably beneficial to everyone to have live in an environment where you have a spectrum, where everyone isn't the same. And I'm referring here now to socioeconomic status, not although that can also apply to race and or ethnicity. Next slide. This interesting study I presented at one of our council meetings, looking at how neighborhood cohesion may buffer food insecurity. So food insecurity is associated with diabetes. They showed that Latinos who reported high levels of neighborhood cohesion and also had a lower risk of diabetes, although the food security was not buffered by that. So this whole idea of how you study neighborhood cohesion, does that really improve or affect outcomes in any way? I think is not a question that has been addressed sufficiently in the literature. Next slide. And then, the things to incorporate is geospatial data. You've heard of the social vulnerability index. It comes from the CDC. When you dissect it, it's really just all these demographic factors that you get from the census and American Community Survey. And I'm not so sure that SES with education help, then you start adding proportion with limited English proficiency. How much does that really matter compared to other things? And then accessing individual data sets linked to census tracts. So we have the SOL data, for example. I mentioned the Hispanic study, and now we're able to get the exact address of all, not that we have the address, but the coordinating center can give us the link, the code for the exact address. So then we can link it to other data that are available for those for those areas. In this case, there's only four. So whether it be tree coverage or walkability or food stores, et cetera. The area deprivation index also is focused exclusively on socioeconomic status, and it is based on the census block. So it's a different methodology, and I think there is some confusion about this. But there are good data that people in most advantaged communities, and this is a study done by UCSF faculty group, after acute coronary ischemia. So you were hospitalized for coronary ischemia, and the 30-day mortality was better for people living in more privileged communities, and the 1-year mortality was 4%, was better as well for those groups. So these kind of factors do matter in outcomes that we all care about as clinicians. Next slide. Let me try and finish up here. So just to re-emphasize the importance of community engaged research. Next slide. Make sure. Management of chronic conditions is really front and center now. Two chronic conditions, 33% of adults, almost 2/3 of those over 65. And yet most of the studies that have been funded or research is focused on one at a time. And oftentimes people are excluded if they have too many things. And most people don't have just one condition. So I think this is an area that we tried again to stimulate more research in. And then you add to this the complexity of preventive measures in primary care. But we're managing diabetes and hypertension and heart disease, or cancer or a rheumatological disorder that the primary care doctor, clinician is involved with. And so all these things I think are ripe for more research. Next slide. This is an example of blood pressure control after a stroke coming out of Florida. And Black Americans in this study were prescribed inadequate medications to control the blood pressure. And this is one time an adherence to, whether it be a guideline, but where you really want to focus on lowering blood pressure as secondary prevention, where we know the risk of stroke is going to be much higher if the blood pressure remains under poor management, poor control. Next slide. And then patient-clinician communication, again, really matters. It is linked to higher satisfaction scores. Race concordant visits for African American patients are longer in studies done by Lisa Cooper a number of years ago. The Medical Expenditure Panel Survey funded by HRQ, African American and Latino physicians care for more than 50% of the minority patients in that study, which is a random sample of US patients, and over 70% of those who report limited English proficiency, and more Medicaid and uninsured patients as well. So, it makes sense to say, well, we need more doctors like that, right? And yet only 14% of medical school graduates in 2022, and that might have inched up a slight amount, and were practicing physicians were underrepresented minorities, either Black, Latino, American Indian, or Pacific Islander. And the same data actually for U.S. STEM PhDs, including the psychologists. So not just basic scientists, are from underrepresented groups. So we have a problem. Next slide. I know we can't talk about it, but we have a problem. Just to end, NIMHD has a Health Disparities Research Institute. It didn't happen in 2025, but there are plans to do it in 2026. I'm told, we usually did it in the summer, 50 early career stage scientists. This is a photo from the one in 2024, and there would be a variety of things involved. So next slide. So I'll just finish with these opinions. So what can science do to reduce disparities? I mentioned this in passing, but standardized measurement of factors that affect health, what we call common data elements, are really critical. As a field, we have to ask questions the same way. And I think that a federal agency like NIH was the place to sort of set some standards. No matter how much, yeah, I was the first one to say, oh, I don't like the way that question is. I'm going to tweak it and ask it this way. We need to really delve into the big data, discovery science, whether with AI or not, collecting data and accumulating data and being able to leverage that is really critical. The importance of community engagement to build trust for sustainable relationships over time is also essential. I think the COVID-19 pandemic, although people want to forget about that, really brought that home. Black Americans and Latinos were dying at 2 to 3 times the rate in 2020. That wasn't true by 2022. And I think that in part was due to the no mobilization of the communities in the face of that adversity. And then effectiveness, I didn't really touch on this. Implement what we know can work. If you know that reducing blood pressure decreases your risk of a stroke, then we should like do 25 things to do that. I don't care about the other prevention stuff as much as I want to make sure that my patients already have an outcome, vascular disease, a prior stroke, get their blood pressure down as much as is reasonably possible with medications. And then the scientific and clinical workforce. Next slide, I think, is just for questions. Thank you. Thank you so much.
Oh, wow, a lot of silent clapping going through the screen here.
Thank you.
As Austin looks at the questions, maybe I'll start off with an easy question, which is, it would take kind of bold action to continue to make these differences. But like I mentioned to you in nephrology, for example, CMS has decided to remove the question about race, which is traditionally asked whenever anyone starts dialysis. So
Mhm.
the easy question is like, so how far back do you think the next, the current kind of attack on some of and you had mentioned the conflating of diversity efforts with some of the more disparity science. How far back will this kind of take us?
Well, you don't ask, you don't know. So I had heard that there was an issue with that. I'm not so sure. I mean, I didn't go and look at the document that you sent me yet, but that is a major problem. Now, under this administration, I don't think we're going to see any changes if people are already doing that. But clearly, all of the large research surveys do collect race and/or ethnicity. They're supposed to do it in the way that I showed you, or make the transition. And health systems, of course, can do this as well. And you can collect race and/or ethnicity. And clearly, I mean, you mentioned dialysis. I mean, chronic kidney disease is a great example of where you have disproportionate burden of disease among African Americans and to a lesser extent among Latinos. And because the underlying causes, diabetes and hypertension are more common. So this would be it is a way to deal with it is you don't ask. France doesn't ask. In fact, it's illegal to ask about race in France. Yet, and they're not a homogeneous population. And it's about 10% are of African heritage and another 10% are Arab heritage, so Middle Eastern heritage. So, we'll see.
Great. Thank you so much for the talk. I can read some questions from the chat here. I think we've been getting them privately, so feel free to continue to
Okay.
direct message us. But one of the questions here is how can um, how we can help address minority pipeline issues when we are being constrained in all directions from talking about race and ethnicity. And do you think there is a better or different way to help in terms of how we approach this pipeline issue?
Well, I wouldn't endorse the idea that we're being constrained to talk about it. Uh, it, as far as I know, we're still able to talk about it. I think the main concern has been not to use it as a factor to make awards or make selections of people or have specific, it should be based on quote merit. There is no rule that you can't talk about race and or ethnicity. People still do talk about it. And if you add to the fact that we have mostly not addressed socioeconomic status for the most part. I think in academics or in research, people have used race and or ethnicity as a proxy for that. And if you focus it as a socioeconomic issue, yes, it will potentially dilute the issues around discrimination and racism that really lead to bad outcomes. But you really continue to move the field in that direction. And there is merit involved in understanding for, the workforce, people coming from underprivileged backgrounds who want to become healthcare professionals, and similarly in the research side. So I don't think that, I don't know, University of Washington is pretty as distant from Washington, D.C. as you can get. Of course, institutions are worried about getting, attacked, like we saw at Harvard or we saw at Columbia, and then they make deals. I think the University of California, UCLA has been attacked, and there have been issues at UCSF that I understand. University of California has 10 institutions. So I would say that, we can't ignore this issue and people continue to evaluate it. So I would encourage people not to abandon this.
Austin, before you go to the next one, Bessie, did you have I saw your hand was up, Bessie, or did it already get answered?
I put the question in the chat and I can read it. I'll just say thank you for coming and speaking with us. We really appreciate it. And I am just, sorry about what happened to you or NIMHD. My question is, I'm just really concerned about our early career researchers,
Yeah.
our residents, and our fellows. And, for those who are interested in health disparities research.
Hmm.
And as an institution, we don't have funds to cover that research, and we're dependent upon NIH for K awards and everything. And how are we going to sort of mitigate the loss that we're experiencing because it's a whole generation of people that we're losing.
Right. Well, first of all, I would emphasize that NIMHD has not gone away. The congressional budget that has not yet been approved includes, the same $535 million budget we had the last 2 years. And so the Congress, for the research side, that those funds are there. We're constrained, or probably NIH cannot do the kind of diversity programs that people had. And most of that was done from other institutes, primarily general medical sciences, but also the other institutes. The diversity supplements went away, things of that type. There was a R01 that was being done linked to people who had worked in diversity, and then they could get an R01 grant or the Mosaic grants. So yes, those mechanisms are gone, but the science is still needed to be done, and the funding for NIH is apparently not going to be drastically changed if they finally pass it. So I would encourage people not to abandon. Now, whether yes, a diversity supplement was a great way to get an assistant professor or a senior fellow started, and you say, you got your first grant. Now we work on, and then they go to a K or something. And of course, the path is just more challenging, right? Diversity supplements didn't exist when I was around. And so I do think that there are ways to make progress, very slowly, very gradually, and not to give up on supporting early career scientists and clinicians in this effort. So, and then I don't know anymore details, but it's hard for me to think that, NCI and NHLBI and NIDA are giving up on this. The institutes that were never too involved with any of these disparities research probably just say, okay, well, we don't do that because we don't want to get in trouble. But the big institutes who have been involved for years, I think will continue to find ways, work around, and not use the language that triggers their responses. The decision to keep grants, is now internal. So I know that NIMHD worked hard with investigators to change their language, modify some of their language, in order to get the grants reinstated. And what will happen in the future, we'll see. I like to be an eternal optimist, although it's been hard lately, and we'll see what happens through this year and whether or not there'll be some modifications in that. So.
And I know we're
So
at 1 o'clock or 1:02 p.m. There's still a couple questions, but Dr. Rodriguez and Dr. Pérez-Stable, in terms of the timing,
I'm happy to
how,
Well,
stay longer. I mean, I have the time blocked.
yeah,
Uh,
he's willing to stay, and other people that can't stay can obviously we're not going to get them in trouble. They can leave. So answer
But
the
I
last
see
couple of
that
questions.
Leo's question about research on impacts of policies on immigrants, I think, that'll be for the future. Obviously, quick local studies will probably happen on the impact of the populations. We see it, and now can we study it to document it? Where people aren't going to work, where you can't get. I mean, just very concretely, one of the apartments in this condo building is only 3 units. The bottom unit, they wanted to get some work done on the outside because they want to put it for sale, and they couldn't find anybody. It took them weeks to find anybody who was willing to do the work because people are afraid to come. And so, yeah, I think that's something to do. And then Austin asked me about what inspired me to become director of the NIMHD. Um, I after I finished medical school, I really loved patient care. I wasn't even thinking about doing research. And while at UCSF, I stumbled onto a general medicine fellowship, general internal medicine fellowship. And at that time, being primary care, general medicine, that was kind of novel back then. So over time, I really developed this love for doing science, doing research, mixing sort of these social issues with clinical ones. But nothing inspired me to come to NIH. It was more like when John Ruffin retired, I thought, well, maybe I should apply. And a few people asked me to apply. I don't know if you might have even sent me an email, Leo, but I know some of my friends did. They didn't reach out to me to say, hey, you should apply. But I did, and then when I went to visit, I interviewed with the committee in person back then, and then went to visit for a second visit. I was really ready to accept, if they offered it to me, because it just seemed like such a good role to be in. And it is. Especially at that time, Francis Collins was the director, the directors were there. So when he called we set up a phone call to offer me the position, I was thrilled. And it was kind of it was a good time for me personally, as one son was finishing college, the other one was about to start. So it kind of like coincided with life well enough. And it is by far the greatest thing I've done in my professional career was being here. So
Well, thanks again. And just a reminder, you were here actually about 8 years ago, not doing I think medicine grand rounds a few years after yours started. So it's great to have you back and to review some of the great work you've done. So thanks again.
thank you for the invitation.
Uh,
Thank you. Appreciate you being here.
Thank you, Austin.